All right. We are live, guys. We are live. And I'm excited. I don't know how excited you are, but I am definitely excited to be here. All right. So you can hear me. Awesome. Okay. So while we wait for more people to join us, the notification is being sent out to everyone as we speak right now. And, we're going to get started. But I would just like to quickly introduce myself as we get started, just so that you get to know me and we get to know you when you begin to speak. I can already see the notification going up and going out on social media. It's such an honor. It is my honor to be here today. Good evening, everyone. Um, this is an amazing, amazing webinar. For the very first time, we are having this webinar on behalf of St. Ives Specialist Hospital to celebrate and commemorate the International Women's Day. St. Ives Hospital is known for women, children, and family. And it's such an honor and a pleasure to be hosting this live program today. If you're joining us, I would like to know your name and where you're joining us from. This will also help guide in terms of when you're asking the questions, so that the doctors are guided in terms of the location that people are joining us from. So I see that we have audience already. I would like to know your name and where you are joining us from. Thank you so much for being here at this time. Like I was saying, is a women, children, and family hospital. And this is the very first webinar that we're putting together. This is brought to you by St. Ives Hospital, like I said, in commemoration of International Women's Day. My name is Kiki Okewale, and beyond the many roles that I play, something that is very, very obvious in the heart of everything I do is I believe deeply in the power of informed choices and community support. And so this is in line with my belief to empower women with the knowledge and the skill that they need. And what better way to do this than to make sure that every woman is. Thank you so much, Rachel from Lagos. Thank you very much. Thank you, Mudukwe from Lagos. Thank you for that. I'm excited to have you here. When women are equipped with the right information, whether about our health, our rights, or our future, we don't just survive, we thrive. And that's why we know that your health and getting informed information as well, you would not only survive, but you will thrive as well. Thank you, Wendy from Lagos. Thank you very much. That is from Instagram. Thank you for joining us, Wendy from Lagos. All right, today promises to be amazing. I'm sure that you already have questions. Today we have incredible opportunity to engage with leading experts. We will answer questions we often ask privately. And I know a lot of us run to, Google to ask questions. But what if you can get a real doctor to answer real-time questions that you have? And I know that personally, I go back and forth checking this and that on Google. But today is such an honor, to have real-time doctors answer this question. So this is your space. This is your moment to ask, to learn, and to leave this place empowered today. So to every woman tuning in, whether you're here to get clarity or you have a pressing issue, simply to just learn something new today, we want to welcome you. I want to also encourage you to be bold with your questions and curious in your approach. Without further ado, it's been 5 minutes. Yeah, I promised to take just 5 minutes, and we're just going to share a brief information about the brand, the hospital that is championing this cause, bringing the experts together, to ask real-time questions. Like we said, ask the experts the health struggles women face and how to fix them. So enjoy, and I'll be right back. All right, all right, all right. That was me just warming up. That's some of the branches by St. Ives Hospital. I'm sure we've seen St. Ives Hospital, Ikoyi, St. Ives Hospital, Akomojo, St. Ives Hospital, Ikeja branch. And we also have a new baby, first St. Ives Hospital, Festac branch. Also, we have a branch in Abeokuta. I'm excited to see that a lot of people have joined us, both on social media and here. We have Ify watching us from Abuja. Thank you so much for joining. We have Thelma from Lagos. Thank you so much for joining. All right, keep dropping your information. It's always nice for us to know your name and where you're joining us from so that when you drop your questions, we're able to personalize them. All right, it is time for us to get started. And I am definitely super, super excited. In another 1 minute, we would be having the honor and the privilege to have with us an amazing doctor who I was privileged to meet yesterday. And I've been super excited. My notes are ready, you can see. I've been super excited, and I can't wait to hear from my wealth of experience. The first doctor we're going to be having today to share with us is Dr. Opeyemi Owosheni. Enjoy our bio.
Dr. Opeyemi Owosheni, MBBS, graduated from the College of Medicine, University of Lagos, March 1999. I'm currently a specialist in gastroenterology and hepatology from the National Postgraduate College of Nigeria. She is presently working at the Federal Medical Center, Abeokuta, as a hospital consultant gastroenterologist. She is a member of the Society for Gastroenterology and Hepatology in Nigeria and the American Society for Gastrointestinal Endoscopy. Distinguished listeners, I present to you once again Dr. Opeyemi Owosheni.
All right. Good afternoon, good morning, good evening, depending on where we are. Thank you for having me on this webinar. I'm supposed to be talking about the health struggles women face with respect to what I do, which is gastroenterology, which is the study of the stomach and the intestine and then the liver. So before I go or delve into that, I must let us know that for most of our cases, there's no special difference, so to speak, unique to women, even though we may have some conditions that are commoner in women than in men. So, but when we talk about the struggles, the health struggles we face, I want to start with talking about the health-seeking behavior, of women versus men. So women tend, first of all, to be more proactive with relationships or with when we relate, to their health, especially and that of their children. And they tend to be the ones who would push their partners, their spouses, their husbands to the hospital whenever they notice there's a problem. Unlike the men themselves who tend to downplay their illnesses until it's so bad and it's almost irredeemable. So the struggles the women face is not just, with respect to their own selves or their own problems. It usually is involving the entire family, their children, their husbands, whoever is, staying with them. So women are more open to, you know, expressing their health concerns to their physicians, to the nurses. They tend to focus more on preventive care, obviously because they know that treatment, is probably going to be more expensive, and they tend to utilize more of the healthcare facilities or health services. For example, when they're pregnant, they are the ones who go for antenatal, they take their children for immunization, they go for dental checkup. So they have, a tendency to want to go to the health, facilities more with respect to their men. However, this, behavior may be mitigated by things like sociocultural beliefs. For example, in the North, a woman, cannot go to the hospital, in fact, cannot go out of her house except she's being followed by a male member of the family, like her husband or her brother. So a lot of times this, you know, hinders their access to health and their ability to receive health care. So, having said that, I also want to say that the health needs of the family usually, lies on the shoulder of the mother, not necessarily the financial aspect in some cases, but the fact that they need to have their children go for the keep their immunization um, clinics, go for their checkups, and do whatever they need to do, especially before they get into school. So most of this depends on the woman. Um, so I would want to now go focus on the conditions in my field that may affect women. So I have mentioned that most of these conditions can affect both male and female. However, a lot of our non-communicable diseases are commoner in men, you know, compared to women. By the time the women become menopausal, when they reach the ages of between 45, 60 and above, the prevalence of these diseases or the occurrence of these diseases are almost now equal. We assume or suspect that it may have to do with some of the hormonal changes that occur in women as they get older. So, some of these diseases would include conditions like hepatitis. Hepatitis is inflammation of the liver, and we have different things that can cause inflammation of the liver. The common viruses that are named hepatitis are A, B, C, D, and E. So hepatitis A, B, C, D, and E are some of the hepatitis viruses that affect the liver. Other things that affect women could be what we call chronic liver disease. It just simply means that there's liver affectation, either structurally or functionally, for greater than 6 months. And the common causes in our environment are this hepatitis B virus, chronic use of alcohol or significant use of alcohol. Sometimes we have excessive fatty deposition. We used to call it fatty liver disease. It has a more complex terminology now. I don't want to say that because of the audience that we have. And then sometimes we have what we call autoimmune hepatitis, where parts of the body, the inflammatory or the um, blood cells that protects, the body begin to attack certain parts of the body, such that if it's parts of the liver begins to become, inflamed, and over time they become shrunken, and then the person may end up with liver failure. So those are common causes of what we call chronic liver disease. And then sometimes we have dyspeptic symptoms or pain in the upper abdomen. So a lot of people just generalize this and say they have ulcer. So stomach ulcers are indeed common causes of this kind of pains, but we also have gallbladder disease or gallbladder inflammation or stones in the gallbladder that can cause pain. Sometimes we have inflammation of the pancreas. So these are just structures that take up the upper part of the abdomen. Sometimes too, you could have what we call gastroesophageal reflux disease, where the acid in the stomach, comes upward or backwards into the food pipe and gives the person some kind of chest pain or heartburn. And then we have finally large bowel diseases. So conditions like hemorrhoids, where you have veins popping out from the anus, commonly in people who are usually constipated or have to strain repeatedly to stool. Sometimes they have what we call ulcerative colitis, that's patchy areas. We have inflammation in some parts of the large intestine or the colon. This is commoner in women than in men. And then we could have what we call diverticulitis, where you have like dimples, inside the colon with little holes inside. So sometimes stool gets stuck inside and the person is in pain. Sometimes because of the stool, it causes some bleeding. So the person begins to see blood in their stool. And then finally, you have what we call things like irritable bowel syndrome. Again, this is commoner in women and it's characterized by lower abdominal pain that is usually relieved by stooling. And then sometimes that person has either constipation, they don't stool very regularly, or they have diarrhea. And then, of course, finally, we could have cancers in any of these, conditions we've talked about: cancers of the colon, cancers of the stomach, cancers of the pancreas, the gallbladder. So these are conditions that are typical to my field where we see women, and these are the kind of conditions, that, I've just mentioned some of the conditions that are commoner in women. However, it affects, both sexes to a large extent. So I think this is the end of my presentation or talk. I'll be happy to entertain questions. Thank you.
All right. Thank you so much, Dr. Wosheni. For the benefit of those that are just joining us, just for us to know that we have four doctors today. They're all going to be having 10 minutes just to lay the foundation for you to know the field they're in and the kind of questions that they would be taking. So Dr. Wosheni just shared a long list of different fields. I think the one that I'm so interested in is the hormonal changes. I'm also very interested in the stomach ulcer you talked about, and of course, to get more information on chronic liver diseases, cancer, and more. So I know that I have questions for when is Q&A. But if you're just joining us, we just had Dr. Owosheni share with us a field of expertise. We're going to be having Dr. Kingsley Obodo. So please start writing down your questions. You can start dropping the question in the chat box. We will definitely answer all the questions. Remember, the questions that come up first are the questions we will take first. So please start dropping your questions. Anything that tallies or questions that you have relating to everything Dr. Owosheni just talked about, we are very happy to take your question. This is a free consultation. Like we said, it is Ask the Experts. So all the burning questions, all the questions you've been asking Google, I know they say Google is your friend, but doctors are friendlier. They are able to actually tell you exactly, what you need to know to get all the information that you need. So it's time for us. Thank you so much, Dr. Wosheni. I'm so grateful. It was so amazing just listening to you and to know all the things that are involved in your field. Wow, it's a whole lot. I pray that you are rewarded on earth and in heaven as well. Doctors do great and amazing work. So I'll bring you back up when it's time to take questions. But right now, thank you so much for being here. All right, so that was Dr. Owosheni, like I said, and I hope that you got all the information that you need. Not to worry, Q&A is coming. So just we have enough time for questions. Just start dropping your questions, whether you're joining us on StreamYard or you're joining us on social media. Please drop your questions now. And I'm sure that as other people start to drop their questions, it will come to you. If you're still trying to, put it together on what kind of question to ask. Awesome. So we are going to our next speaker now. Our next speaker is Dr. Kingsley Obodo. Now, for those of you that are joining us on social media on St. Ives Specialist page, I'm sure that is not a face that you do not know. Every time we have it on our live, the live is always bombarded with questions. So we are having with us again today Dr. Kingsley Obodo. I'm going to share his bio with you now, and we're going to bring him up stage. Get your questions ready, guys.
Dr. Kingsley Obodo is the Deputy Group Medical Director of St. Ives Specialist Hospital and a highly experienced specialist in reproductive health and fertility care. With years of expertise in assisted reproductive technology, ART, he has helped numerous couples achieve their dreams of parenthood. Passionate about patient-centered care, Dr. Obodo is committed to providing advanced and compassionate fertility treatments. Distinguished listeners, I present to you once again Dr. Kingsley Obodo.
Good evening, everybody. Once again, I count it a great honor and privilege to be part of today's webinar. Let me begin begin by celebrating and saluting all our women folks out there as the world marks the International
Doctor,
Women's
but I'm
Day.
sorry to interrupt you, but there's a noise. We can hardly hear you. I don't know if it's your headphone, but there's a noise that is really loud.
Apologies for that.
Okay.
Okay, is that better?
A lot better. Thank you so much. I'll be out of the stage. Thank you.
Okay, okay, all right. So let me begin by celebrating and saluting all our women's folks out there as the world marks the International Women's Day. Want to especially celebrate our women's folks out there as for their courage, their resilience, and their resourcefulness. Women are the backbone of the family unit. And in extension, they are also the bedrock of every nation. Because why? They bring life into existence, into the world. The theme of this year's International Women's World Day has been tagged as accelerated action. And there cannot be any accelerated actions without information. So information is key because we know that knowledge is power. One way of getting empowered to taking charge of your own health issues is having the right information. And in this case, having the right information that relates to the women's health. And this has been the core value and the core agenda with us at St. Ives. From our various consulting rooms to our weekly Instagram live programs, and also various forums like this one now, inclusive of these ones, where we try to shed more light on the issues concerning women's health, thereby demystifying and also breaking the various myths that has been associated with the women. For instance, you talk about infertility. In the past, people have been attributing, when it comes to with society, in our present society, people attribute that infertility is the woman's issue. But we know that the men are also highly, very, very equally involved in this issue. And also in terms of gender selection, gender determination, we know that the woman really plays really little or no part in gender determination, but the man himself. And also through the various other issues relating your menstrual regulations, menstrual cycle issues, menstrual disorders. When you have informed information, you are able to better manage and control this. And also, women should also have informed information that regards to fertility preservations in this day of modernization, where people delay conception to later date. So they should have information that would regard to various ways of having to preserve and retain their fertility. And also, fertility, which is a major issue in this part of the world, should be demystified, and women should know when to seek help and where to seek the right help. Also, we talk about issues that relates to cancer preventive measures, especially that relates to the women. This includes the self-breast examination, the monthly breast examination for people, prevention of early detection of breast cancers, to our routine cervical pap smear for early detection of cervical smears, and also your simple basic pelvic scan that can help also to determine, to detect, and also early cases of ovarian cancer. So the list goes on. But the key thing why we're bringing to this thing is for information. And not only getting information, but getting the right information. And when a woman is equipped with this information, she's able to also manage. And also the pressure that is put on these women are also reduced, because a lot of pressures are on these women, because we know that it is not the woman's issue. It is not the woman's problem, but it is the couple issue. And this should be seen. So this is one of the things, this is the key things that we need to pass across to our society, not only to our religious bodies, to the community, so that pressures are put off from the women folks. So as we go along, hopefully we should be able to shed more light as the question keeps coming on. So I want to broadly stop at this light. Thank you very much once again for having me. Happy International Women's Day celebration ahead. Thank you.
Thank you so much, Dr. Bodo. Thank you so much. Wow. Thank you. That was amazing. And yes, acceleration for women is very, very key. Thank you for sharing your wealth of knowledge. I'm sure that we already have questions for Dr. Woshini, but we will wait until all the doctors are done with their 10 minutes foundation talk, and then we will move to Q&A. So let's try and keep it within 10 minutes so that we can take the questions, because we're having a lot of questions already. And in answering questions, we'll be able to shed more light on the things we want to talk about. We're going to bring up now, yes, we have lots of questions already. Wow. We're going to bring our third speaker up now. Once we bring our third speaker up, she has 10 minutes. We're going to bring our fourth speaker, and then we will start responding to all the questions that we have. So whether you have a question for Dr. Wosheni, or you have a question for Dr. Kingsley Obodo, or you have a question for Dr. Okunuga or Dr. Babatunde, we will take all the questions after the foundation message has been dropped, because we know that if we start taking the questions, we're not going to have enough time, for other doctors to give foundation. And the foundation is very, very important, because this helps you understand the doctor better and the field that they're in. All right. So I've been running away from pronouncing Dr. Wosheni's field. It's gastro and oh Lord help me. I did try to practice that over and over. Forgive me because I'm not a doctor, but I'm bringing on board now Dr. Okunuga, consultant cardiologist. Yeah, I can pronounce that very well. I'm going to go learn more on Dr. Oshedi. She should find me for this. But yes, we are bringing up now Dr. Sheung Okunuga. Enjoy a bio as we bring her up stage. Thank you.
Dr. Sheung Okunuga graduated from Olabisi Onabanjo University, Ogun State, with MB.CHB. Housemanship was at University College Hospital, Ibadan. She had her residency program at Lagos State University Teaching Hospital, Ikeja. She received award of the best candidate in the Part 2 Faculty of Internal Medicine exam when she obtained her fellowship FMCP, and has since become a consultant cardiologist and was retained at LASUTH, Ikeja. She is a member of Nigeria Cardiac Society and the European Society of Cardiologists. She is married with kids. Distinguished listeners, I present to you once again Dr. Sheung Okunuga.
Okay. Good afternoon, ladies and gentlemen. All protocols duly observed. So I'm Dr. Okunuga, and I'll try to keep within the 10 minutes because I think I have more to say, but I'll try to keep within the 10 minutes. So I'm a cardiologist, and I would speak as a cardiologist. Again, as Dr. Woshini had said, most of the diseases kind of like are the same in men and women. But the reason why there are few exceptions to the rule, but for the most of the things that I'll be talking about today, they are just to like inform us as women, because we play a vital role in the family unit. So I'm going to be talking about cardiovascular diseases, so to say. So what do we mean by cardiovascular diseases? It simply means heart diseases or diseases that affect the heart. So, but these diseases that affect the heart, they are largely preventable, okay? For the global or worldwide, in the United States and worldwide, at least out of 3 deaths, sorry, I'm starting with deaths, but this is to inform us so that we won't get to that stage, so that we will be able to do things that will be preventable. So cardiovascular diseases, meaning that diseases that affect the heart, they are the largest cause of deaths. So if 3 people die, at least 1 out of the 3 people would have a heart disease, will have a cardiovascular diseases. And these diseases are largely preventable. So, and these diseases can affect newborn babies, teenagers, and adults. So the reason why we are talking to women is because we know that we can play a vital role in identifying these diseases. Even when a child is born, we'll be able to tell the doctor, because as a cardiologist practicing in Nigeria, we get to see patients in their adulthood with hole in the heart. This is not supposed to be, because abroad, once a child is born, they detect all these things. And this, so we know that people deliver in all sorts of places, but this is why we are bringing this to your attention, so that once a child is born, irrespective of where the child is born, even if, because I don't want to say the kind of places that people deliver in this country, but once a child is born, if, for instance, you are just hearing this and you're pregnant, or you'll be getting pregnant in the nearest future, once your child is born, let them listen to the chest. They should just put a stethoscope to the heart to listen to the chest, just to listen, and they will pick murmurs. Okay, now these murmurs, when they are picked, usually we'll be able to tell them the test to do, and they'll be able to identify diseases that the child was born with that affected the heart, which once they do surgery at that age, within the first 1 year of life, the child will live a normal life. But by the time, as cardiologists in Nigeria, we are seeing grown-ups 50 years, coming to the clinic with diseases that they were born with. At that time, it is almost difficult to do a surgery. So the patient will just live like have a bad outcome. This is something that could have been preventable by just putting a stethoscope to the heart. So if, for instance, this has been missed, you already have your children, you don't know whether a stethoscope was put to the heart or not. So when you take them to the clinic, just tell the doctor, please help me listen to my baby's heart, or my son's heart, or my daughter's heart, and they would hear murmurs. It's usually loud enough for them to hear. So that is the first thing. So we want to tackle heart diseases in children. Okay, so the ones that they are born with can be easily taken care of with surgeries, and these surgeries are now done in Nigeria. Most of the simple ones are now done in Nigeria, and for the ones that are very complicated, we will refer you to appropriate places where they will be done before they are 1 year old. So that is the first one for the children that are born. The second one is for children between 5 to 15 years of age, when they have fever, joint pains, they have sore throat. Don't assume that it is malaria. It is not all fever that it is malaria. Don't just go to the nearest pharmacy and buy paracetamol or anything the pharmacist prescribe. Please bring your children to the hospital. It is very, very important once they have fever. So we know that there are some fever that are just viral that can go. We know that it can be malaria, even malaria. You shouldn't just treat malaria. Bring the baby to the hospital, let them treat it. But where it concerns cardiovascular diseases is that there's a disease that is called acute rheumatic fever. Now, this disease is a disease that usually the child would have had a sore throat. But remember that a 5-year-old may not be able to tell you that they're having a sore throat. What you would see would be that there's a fever. They may just not want to eat, and most mothers will just generally say it is malaria. No, it may not be. It may be that the child is having a sore throat and there's an infection caused by streptococcus, a bacteria that can affect the heart. And when it affects the heart, it can damage the door of the heart, one or two of the doors of the heart, which if you bring your child to the hospital and they can detect it, they just look at the throat, they do some tests, and then they give 10-day antibiotic. That is it. The child is fine. But if you miss that period, a child with fever, sore throat, joint pains, and you miss that period, and then that settles down. So it will still settle down. So you will think that disease has gone, but it has affected the heart. So 15, 20 years down the line, the door that is actually called a valve in medicine, but it is a door between two rooms of the heart. So that door may not be closing well, or may not be able to open well, and eventually may lead to the child needing open heart surgery. So this is a preventable disease that could have been prevented by just treating that infection with 10-day antibiotic, and they have the antibiotic that we use. So you also cannot just go to the pharmacy and just buy any antibiotic, because it would not work. And remember that the infection may go, and you would think that it has gone, but really it has caused a heart disease that is very, very severe. Okay, when people have heart diseases, it will result in heart failure. So for babies, for the ones with this fever, that was not treated, it will result in heart failure. And when we say heart failure, we mean that the child walks after, usually when it will present as heart disease, it may present at that time when it's very serious. As a child, it may present in heart failure, but it may not present in heart failure and may be missed at that time. So 10, 15 years, 20 years down the line, then there will now be florid heart failure, and the person will walk a short distance, will be tired, the tummy will look like pregnancy, the leg will be swollen, and they will need an open heart surgery. And sometimes by the time we are even diagnosing it in adults, we may not even be able to do that open heart surgery again. So please, let us not treat fever on our own. Let us bring these children to the hospital. Let them make the diagnosis of whatever it is. Let them say it's just paracetamol, it is malaria, it is infection of the throat. They'll be able to look at the throat for you. Okay, so that is as regards our children. Now, as regards us as women, in Nigeria, practicing as a cardiologist, the commonest disease that we see is hypertension. So again, there's always this 1 in 3. You pick 3 people randomly, not in the hospital, just go anywhere to the market, and sometimes we just go to the market church, we just want to do screening and we do blood pressure. At least out of every 3 people, adults that we pick, 1 person will have hypertension. So hypertension is epidemic in Nigeria, and hypertension is a treatable condition. I mean, once you check your blood pressure, depending on the readings, all you just do is lifestyle modification, which if 10 permits, we'll talk about the lifestyle modification, and some will require medications. And usually once we start you on medication, it is usually for life. Now, if you don't check your blood pressure, you may not know, because it is a silent disease. By the time you are noticing complaints like difficulty with breathing, headache and all that, then the hypertension has been there for many years. So usually when hypertension is first starting, you won't know that you have hypertension unless you check your blood pressure. And hypertension can result into heart diseases, starting from hypertensive heart disease, heart failure, heart attacks, and these diseases are preventable, okay, by you taking your drugs. So you prevent things like hypertensive heart disease, heart failure, heart attack, strokes, kidney disease, by you taking your drugs, okay? So other diseases, we call them like cousins of hypertension. You should check your cholesterol. So if the cholesterol is also high and is not treatable, and it is not treated, it can also result in all the diseases that I've called. Diabetes mellitus is also another disease that is also very common in Nigeria and even worldwide. And all you need to do is just check your blood sugar. So if you check your blood sugar once a year and it is normal, just check it once a year, so that by the time, if you eventually become diabetic, you know that it is at least 1 year ago, than less than that it started. It will not have caused any of the bad things that it can cause. Okay, so let's talk about, and then obesity. For as a woman, we should check our waistline. So just use like a tape rule and measure your waistline around your belly button. It should be less, for a man, it should be less than 102. For a woman, it should be less than 85 centimeter. So one of the reasons why we gained weight, so after childbearing, we have to do lifestyle modification. Again, we'll get to that. But one of the 2 things that we should avoid is eating late at night. So we should not eat after 7 p.m. Don't wait for your husband. Don't say I have to wait and eat with my husband, and your husband is going to come back at 11 o'clock. No, dinner should be taken before 7 p.m. Okay, so in pregnancy, let's register for antenatal on time, because if you register for antenatal on time, usually within, if the first 3 months they found that you have hypertension, that means that you've been hypertensive. It wasn't the pregnancy that caused the hypertension. So pregnancy-induced hypertension usually start from like 20 weeks of pregnancy. So the fact that if you come in at the first 3 months, they didn't detect hypertension, doesn't mean just keep coming so that when they detect it, they can treat you. And so it will avoid all the harmful things that can come to you or to your baby. Again, gestational diabetes, which is diabetes that occur in pregnancy, too, can be detected during antenatal. Now, so pregnancy-induced hypertension and gestational diabetes usually would go after delivery, but it may come back after years later. So you need to keep checking your blood sugar and your blood pressure as a woman, and you should also encourage your family, your children, your husband, to check their blood sugar and their blood pressure. Now, there's a very terrible disease that pregnancy can cause that can affect the heart, which is called peripartum cardiomyopathy, meaning that in the last month of pregnancy or 5 months after delivery, so when you get home and you just find that you are just unnecessarily weak, tired, breathless, your leg is still swollen, you are coughing, it may be that so you are no longer pregnant again, but you still have, because peripartum, it means around pregnancy. So in the last month of pregnancy and 5 months to 6 months after pregnancy, those are heart failure related symptoms that the pregnancy has caused, and you need to present to the hospital immediately so that we can start treatment, so that the heart, because what usually happens is that the heart gets big and is not pumping blood well, and that can cause death if you don't come to the hospital. So if you come to the hospital and we give the good drugs, then you'll be fine. So obesity, hypertension, diabetes, sedentary lifestyle, just sitting in one place, asking somebody to get your remote, they are serving your tray, your food for you, all those things, stand up. Take the remote yourself. Don't call your children to do these things for you, so that you are not sedentary, because if you are not moving well, then it can cause heart diseases. So finally, how do we prevent this heart disease? How do we treat hypertension, diabetes, high cholesterol? So I have just a minute, so I'll just quickly round up on how we can prevent these diseases. So one is exercising. So we need to exercise, at least move, walk fast for 30 minutes every day, or at least 5 times in a week. So we have 7 days in a week. If you can do 5 times a week of 30 minutes walking, jogging, dancing, swimming, any of them, they are very good. Reduce salt in your food, eat lots of vegetables and fruits, okay? Sleep at least 7 hours in a day. Okay? All those things are very helpful. Don't smoke. Reduce alcohol intake. If you cannot stop, reduce it, but as much as possible, it will be better and preferable for you not to drink alcohol. But if you must drink alcohol, for like Smirnoff Ice, half a bottle of 5% alcohol. And I hope that we'll be able to talk about more of lifestyle modification after this presentation. So thank you very much.
Wow, 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 wow. Dr. Okunuga, you need to pay me. You need to pay me, because, oh my God, for 1 minute, you're like, no, and now it's like we don't even want you to stop. We don't even want you to stop. I mean, if not for time, I mean, look at my notes. It's actually full. Thank you so much, Dr. Okunuga. Me, I have personal questions, plenty. But when it's time for question, I'll take that of my audience first. And then, of course, I'll ask my question. Thank you so much for not just mentioning the kind of diseases, but what we can also do to prevent the diseases. Wow, wow, wow. This is quite interesting. It's such an eye-opener for our women. And I know you did mention that this is not just peculiar to women, but, like we said, because we're using this platform to commemorate International Women's Day. And so our audience here today is largely women. But wow, what a presentation. Thank you so very much. Next time, do not even tell me that you're not going first. Do not tell me you only need 5 minutes. Just have the floor, okay? Just own it. You were actually made for this. Thank you so very much for such a detailed presentation. All right. Thank you. So we'll be bringing you upstage very soon, because we have a lot of questions for you already. In fact, I have a lot of questions for all our doctors already. Wow. Wasn't that amazing? I bet it was. And I'm sure your notes are filled up if you're writing down like mine, or your questions are piling up. keep dropping your questions here on StreamYard. Keep dropping it on social media. We are collating all the questions. And as soon as we're done with our final speaker, which is what we have now, we're not here to waste time at all. Everything is pam, 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 so that you can ask all your questions and we can take all your questions. Remember, this webinar is brought to you by St. Ives Specialist Hospital. In case you don't know, St. Ives is known for women, children, and family, and of course, fertility experts. So we're excited and we're grateful for the opportunity to bring amazing doctors like Dr. Owosheni, Dr. Okunuga, Dr. Kingsley Obodo, and now we'll be having the final speaker and the chairman, CEO of St. Ives Specialist Hospital. What an honor. What a privilege to be able to have this lineup of speakers. Thank you. We do not take it for granted. As a doctor, we know how busy you are, and we know that you could have been doing anything else. Even if you're not working right now, you can just be resting because your days are always busy. But here you are sharing with us and helping us learn and become better versions of ourselves. Thank you very much. So we're going to have our final speaker now, after which we'll start taking questions. If you're just joining us, you're still right on time. We're going to start taking questions as soon as we have our final speaker, which we are having now. So we're going to show you the bio of Dr. Babatunde Okewale, and it would have 10 minutes as well to share with us, after which we dive deep into questions. I'll let you enjoy his bio. Thank you.
Dr. Babatunde Okewale is the founder and chief medical director of St. Ives Specialist Hospital, the leading multi-specialist healthcare provider in Nigeria, a distinguished consultant, obstetrician, and gynecologist. He has dedicated his career to advancing women's health and fertility care. With decades of experience in reproductive medicine, Dr. Okewale has played a pivotal role in shaping assisted reproductive technology art in Nigeria, helping countless families achieve their dreams of parenthood. Beyond his medical practice, he is a visionary leader, driving innovation and excellence in healthcare delivery across St. Ives Specialist multiple branches. Distinguished guests, I present to you Dr. Babatunde Okewale.
Hello, everybody. My name is Dr. Babatunde Okewale. I'm a member of the British Fertility Society. Now, I'll be sharing a little bit on fertility perspective today. And it's really a big honor for me to be part of this International Women's Day celebration. Now, infertility is a disease. You heard me right. It is a disease because a lot of people don't see it as a disease. And partly the reason for that is because it doesn't cause physical harm. A lot of people think it shouldn't be a disease. But the World Health Organization has declared infertility as a disease. Infertility is defined basically as the inability of a couple to achieve pregnancy in 1 year after having regular, unprotected intercourse. Now, why is it a big problem? The truth of the matter is 1 in every 4 couples that you see today are suffering from infertility. And the challenge is we don't want the statistics to get worse. Now, why do we need to address infertility, or why is it so important? It is a human rights issue, and a lot of people don't even see it as that. Fertility is part of the reproductive health right, which is a form of human right. Now, part of the reason why it's been classified as a disease is so it causes mental and social health problem in a family. And the truth of the matter is, when there is a couple and they are suffering from infertility, the assumption straight away is it is the woman who has the problem. Infertility can cause domestic violence. Infertility can cause divorce. It can cause separation. It can cause social stigma. It causes emotional stress. It causes anxiety. It causes depression. It causes low self-esteem. It causes the so-called illegitimate or children out of wedlock. And finally, it causes third-party sex. That is, a strange woman comes into the family. And a lot of times, when the DNA issues prop up, it might not even be their child. So when you look at that, it causes social problem, it causes mental health issue. WHO has now declared it, and emphatically and rightly so, as a disease process. Now, the next question is, why is infertility a rising problem? Suddenly, in the days of our fathers and mothers and grandmothers, it wasn't this bad. In the biblical days, even in the Bible, the infertile couples are far and in between. Maybe Sarah, maybe Rachel, but not this one in every 4 couples. And part of the reasons in the present day could be distilled into the following. The issue of urbanization. We're all living in the big cities now. We've left the rural area. And it's been found that infertility, the cases of infertility, is higher in the urban centers than in the rural area. In fact, a study was made that showed that the sperm quantity and quality of men in the urban areas like Lagos is far, far lower than men in the rural area. And part of the urbanization problem has to do with pollution. There's a lot of pollution in the system, industrial and domestic pollution. When we talk about pollution, we're talking about smokes from the heavy machineries in the industries and from even the indiscriminate use of generating sets in our society. What does it cause? It causes reduction in sperm count, and it also causes reduction in egg production. Part of the urbanization problem, again, has to do with chemical exposure. There are a lot of companies, especially the plastic and the printing industries, that produce certain chemicals and solvents that are very harmful to the sperm and also to the egg. And they dispose of these chemical pollutions or indiscriminately, again, in a way that they pollute our water system, both the public and the domestic water system, especially the boreholes, in the way they are done. Now, there are other chemicals like pesticides, heavy metals, mercury, things like that, that are pumped out from these industries that also affect infertility and has made it a rising problem. Another issue is the career orientations, especially of women in this day and age. Women are working more than at any other time in the history of mankind. And for a lot of them, they are becoming the breadwinners in the family. So you find a lot of women who are delaying marriage because of their career and for financial reasons, because they are the breadwinners in their family. And we know that as the woman ages, the quality and the quantity of their egg starts to drop. In fact, it starts to drop at a very fast rate from age 35. So that's a big problem, age and late settlement in life. Then we have the issue of infection. The kind of infection that are causing infertility today is different from the kind of infection that were causing it about many decades ago. Many decades ago, we talk about gonorrhea and the rest. But with the proliferation of so many antibiotics, we rarely see that in this day and age. The kind of infection we now see is called chlamydia, and it's a silent killer. It doesn't give any warning. And before you know it, because it gives little or no symptom, it has destroyed the reproductive tract of both the male and also of the female. Now, one of my colleagues has talked about lifestyle. Lifestyle matters a lot in infertility. And when we talk about lifestyle, we're talking about the body mass index, eating habits. Obesity is directly related to infertility. Obesity is directly related to polycystic ovarian syndrome. Polycystic ovarian syndrome does not allow a woman to ovulate. So there is a link between lifestyle and fertility in women. Again, in the urban centers, the kind of food we eat, the junky foods, irregular eating of fatty foods and the rest contributes to the rising incidence of infertility. Before I stop, I will quickly want to talk about religious dogmatism, which is very common in our particular environment. A lot of people that would have gotten help from infertility leave it a little bit too late because sometimes they feel that their faith and seeking medical help mutually exclusive. It shouldn't be that, faith and seeking medical help should go hand in hand. And don't forget, I said, age is one of the critical factors in infertility. The older a woman goes, the more that the quality and the quantity of their eggs starts to decrease. I think I'll have to stop here so that we can have a lot of questions relating to infertility. Thank you.
Thank you so much, Dr. Babatunde. Thank you so much. That was, as usual, very, very informative. Thank you. In case you're just joining us, that was Dr. Babatunde Okewale, consultant gynecologist. All right, it's been an amazing about 1 hour now. We're keeping to time, and I'm happy about that. It's time for Q&A, and we have a lot of questions. So what I'm going to do is I'm going to bring all the doctors, the amazing doctors that we've had upstage. And as we bring the question on the screen, I'm sure some are very explanatory. We'll know what the questions are for. But for the ones I don't know, the doctor that would take that would let us know. So yeah, lots of questions. I see it. But let me go ahead and bring Dr. Wosheni. Can we have, thank you to all our doctors. It would be nice for us to appreciate all the amazing doctors that we've had here today, sharing from their wealth of knowledge and wealth of experience. If we're actually to go to the hospital to have consultation, I'm sure it's not going to be free, right? And I also know that some of the doctors, we've had questions talking about where can we consult, where are your hospitals? So when the doctors come up, maybe they just 1 minute share with us the branch, where they work and how they can be reached before we start taking questions. For those that are on the TeleDoc app, do share your information so that people can consult with you virtually as well. I'm not sure if Dr. Okunoga and Dr. Wosheni is on the TeleDoc app, but if they're not, I want to encourage you to be on the TeleDoc app because patients can get to consult with you virtually. I mean, I want to consult with you, so I know that virtually it makes my life easier. And, we will. So I'll bring my doctors up stage now. See me saying doctors. I'm not a doctor, but see the way I'm bringing doctors up stage. That's how we roll. All right, so I'm bringing Dr. Owosheni up stage now. Thank you so much, Dr. Owosheni. I'm bringing Dr. Kingsley Obodo up stage. And I am bringing Dr. Okunoga up stage as well. Thank you so much. I'm not sure I've been in the midst of so many doctors like this from different fields. Thank you for the privilege and the honor, and thank you for sharing with us. We have a lot of questions for you. I'm going to go up and start, but before then, I'd like to start with Dr. Owosheni. I know in your bio we did mention where you work, but if you can just give a brief information or maybe your email, your phone number, or anywhere people can reach you, because once we start question, we just keep going, and at exactly 6 p.m. we are going to stop the webinar. So I just want you to take 1 minute each to share this information. Over to you, Dr. Wosheni.
Okay, so thank you. I do work at the Federal Medical Center at Idiaba in Abeokuta. My phone number is 0802 318 8626. So that is 0802 318 8626.
All right. Thank you very much, Dr. Wosheni. Over to you, Dr. Kingsley Obodo. Dr. Kingsley, we can't hear you. We can't hear you. It looks like you're frozen.
My name is Dr.
We can
Kingsley
hear you
Obodo.
now.
Can you hear me now? Yeah, my name is Dr. Kingsley Obodo. I'm a consultant obstetrician and gynecologist. I work with St. Ives Specialist Hospital, presently consulting at the Ikeja branch, Mondays, Tuesdays, Wednesdays, and Fridays. And I'm at the Festac branch on Thursday. I can be consulted via the TeleDoc app. You can search for me there, download the app, and we can get to talk virtually. Thank you.
All right. Thank you so much, Dr. Kingsley. Over to you, Dr. Okunuga.
Okay, my name is Dr. Okunuga. I work at Lasut Ikeja. I'm a cardiologist. My phone number is 0806 350 1091.
All right. Yeah, you can take it again. 0806 350 1091. Did I get that right?
Yes, ma'am.
All right. Thank you so much, Dr. Okunuga. Over to you, Dr. Okewale.
Yes, my name is Dr. Babatunde Okewale. I work at St. Ives. I can be reached via the TeleDoc app for consultation, or if you call the hotline of the hospital, they will be able to link you up with me via the TeleDoc app. The hotline of the hospital is 070 424 6413. Thank you.
All right. Thank you very much. So I take it that Dr. Owoshene and Dr. Kuniga are not on the TeleDoc app. We are coming to you immediately after this session. You have to be on. That is the app to be, because patients get to consult with you from anywhere in the world virtually. And definitely, it is not free. You get paid for your time and your service. So it's not that, they want to come and take our time again. No, absolutely not. And that's just me talking on the side. So we have questions. The first question I'm going to put up here, I want to believe this doctor is for, this question is for Dr. Owoshene. Am I correct? It's about liver cirrhosis.
Yes, symptoms of liver cirrhosis and how it can be
prevented or cured.
Prevented, yes. So the first thing we should know about liver cirrhosis is that there are no symptoms, especially in the early stages. So the only time you get symptoms are when it's already advanced, and more often than not, it's usually too late. So by that time, less than 25% of the liver reserve is functional. So you must know first and foremost that there are no symptoms in the early stages when things can be sorted out. Now, when it's advanced, a person may have yellow discoloration of the eyes. They may have protruding stomachs, so there's water. It seems to be fluid accumulating in the stomach. Sometimes it gets so bad that the legs are also involved. Then some of these people may end up with poor sleeping habits. So they find out they're sleeping during the day and they're awake most of the night. They become irritable when it's advanced, they begin to talk irrationally, and sometimes they become unconscious. A few of them may end up with kidney failure. So by the time their symptoms or any of these features of liver cirrhosis already advanced. And how do you prevent it is to know the causes. When I talked about, liver cirrhosis or chronic liver disease, I listed some of those causes. Now, in the process of going to the hospital, going for medical checkups, even when you are not ill, is very important. So in the process, you do some of these tests we call screening tests. You check out for, look out for hepatitis B, hepatitis C, which are the common causes of liver cirrhosis, B, especially in this environment. And if it is positive, you need to be linked up with a specialist or at least somebody that knows how best to manage such a condition. And if it is negative, we are advised to go for vaccination. If the hepatitis C is positive, again, we are linked up for, specialist, somebody that knows how best to treat. Fortunately, there's cure for hepatitis C, most cases of hepatitis C now. And then things like alcohol ingestion, Dr. Kunuga has told us that as much as possible trying to minimize, but we really don't have any safe dose or safe amount of alcohol. So the teaching is, try to abstain. I know a lot of people don't want to hear that, but that's actually the safest thing to do with alcohol, is to abstain from alcohol entirely. So the treatment or prevention for liver cirrhosis essentially is to look out for all the possible causes, and then avoid them or treat them before they become a problem.
Wow. Thank you so much for that response. All right, so the next question is not eating a cause of ulcer, as always speculated? I eat fairly well and I still have ulcer.
Okay, so that's a very interesting question. And actually, that was why I brought it out as a complaint of upper abdominal pain, because everybody, including our colleagues, that's the doctors, they a lot of times when a person has pain in the upper part of their stomach, it is ulcer until proven otherwise. A lot of people don't even know what ulcer actually means. An ulcer is basically a wound. You cannot say that a person has had a wound in his stomach since childhood. So I get to hear a lot of people say, "Oh, I've been having ulcers since I was a teenager," and then I have to ask them, "Does that mean that you have had a wound in your stomach since you were a teenager?" So pain in the upper aspect of the stomach can be caused by so many things. It can be caused by this stomach ulcer, truly, but it can also be caused by what we call gallstones. So there's, the gallbladder is that greenish little round thing that is, hanging just below the liver. I tell them, if you've ever killed a chicken or seen them killing a cow, that round greenish structure that they try to avoid opening up because it will make the meat bitter if it's spills out. So people that can understand that. So when there are stones in that structure in human beings, sometimes it can cause pain. So, and it is going to cause pain in the same part of the anatomy that people think is an ulcer. Sometimes they could have pancreatitis. So the pancreas is also located in that area. And if there's inflammation of the pancreas, it can have pain. Sometimes when the liver is also inflamed, it's located in the same area. So because a lot of structures are located in this same area, if any of those structures that have diseases or inflammation or disorder can give pain. So this ulcer that you talk about, you need to be sure of what it is. So, and then we have stomach ulcers that truly, when you eat, it gets better. When you're hungry, it gets worse. But you also have some that when you eat, it actually gets worse. When you're not hungry, you feel better. So if you're having a pain that doesn't improve when you eat or when you take the anti-ulcer medication, then you must have it investigated, because it just might not be an ulcer. And don't forget, ulcers should heal. If you have an ulcer that is not healing, it is most definitely not an ulcer. You must have it checked.
Wow. Thank you so very much. Okay, so I'll just give Dr. Obodo two questions. I'll take it to two questions so that everyone can answer. All right, Dr. Obodo, the question is, I would like to know, how can I prepare well for a successful IVF? What are the things I need to do? Dr. Obodo, we cannot hear you. We cannot hear you. We can hear you now.
Okay, I said thank you for that question. Now, to prepare for a successful IVF, What I normally tell people is that, number one, you must have confidence that IVF is going to be successful. Your faith, your belief is very, very paramount. Okay? Can you hear me? Okay. So your faith and your belief is very, very paramount. That is going to succeed. That is number one. As we know that IVF, although IVF is 30 to 60%, but we know that once your mindset is actually on the right, once you create a right vibes, right attitude towards the treatment program, it is bound to succeed. That is number one issue. But in order to prepare for successful IVF, number one is for you to make the right information and make it on time. Like the chairman mentioned, that most people take decision and they take a decision when the decision is quite late. So number one issue is to make the right decision that, look, my own case of fertility treatment requires an IVF treatment. Then the second thing you need to do is to go for evaluation. And this evaluation will now determine what form of treatment that will be required. Then the third thing again is that there are other conditions that could also affect the success of your IVF. If you have pre-existing medical conditions that needs to be sorted out, and your doctor, fertility doctor, will be in the right position to advise you. People who are chronically hypertensive that are poorly controlled may need to have such hypertension dealt with. People who have uncontrolled diabetes, they need to have those sorted out before coming in for treatment. And also people who have thyroid diseases, thyroid issues, either hypothyroidism or hyperactivity of the thyroid gland, what we refer to as hyperthyroidism, they need to also consult an endocrinologist and have those disease conditions normalized before even venturing into an IVF treatment plan. Then I always say supplements. Some supplements are also very, very crucial. Like the neurothoracic surgeons will advise, that any woman trying to conceive at least should be on this supplement, folic acid, at least 3 months before conception, because we know that folic acid helps in the neural tube development of your baby, to avoid neural tube defect. So those are the things that we need to. Then also you must trust the process that is going to work for you, and it will work.
All right. Thank you so much, Dr. Obodo. The next question is still for you. Why does fibroid grow back even after surgery? Is there a way for women to prevent its regrowth?
Now, yes, occasionally you might have, following fibroid surgeries, you could have regrowth of this fibrous surface. Now, the reason why there's a regrowth, talked about the fact that there could be some genetic component to the development of fibroids. When you're talking about the etiologenesis of fibroid, some people have the tendency to have very big fibroid. Some have the tendency, even though they have fibroid, the fibroid doesn't grow beyond certain sizes. That is established. Now, for people who have recurrent of fibroid, what can occur where recurrence? When there's a fibroid surgery, which is what they call myomectomy, the goal of every surgeon or the gynecologist is to remove as much as all the visible fibroid nodules or shedding of the fibroid nodules. But occasionally, you may have some tiny ones that are still there that may not be visible as of the time of the surgery. Such fibroids can, if those group of people have that propensity of the genetic propensity of having big fibroids, over time, it could regrow. Now, how do you prevent that? We talk about that nature abhors a vacuum. Immediately after a fibroid surgery, for people, number one is either to take the fibroid surgery to take decision of having the fibroid surgeries at the right time. Some people go in to have fibroid removal too early, and they now delay in trying to conceive. And over time, those small fibroids that were not apparent at the time of surgeries, they grow back. And that is just the sad scenario. So my advice is that if you want to have the fibroid removal done, it should be done at the right time. Then if you are also trying to conceive, is to probably try and get pregnant. That can also reduce the rates of the growth of such fibroids. So that's just my take. Occasionally, there's little or nothing that the woman can do to prevent the regrowth. There's no dietary, no food intake or anything that you could do that could probably stem the tide of the growth of this fibroid.
All right. Thank you so much, Dr. Obodo. Thank you so much. All right. So my next question is for Dr. Okunuga. And it is that, Dr. Okunuga, thank you so much. So I don't smoke, I don't drink alcohol as much before now. I play football always, but now I get tired faster than I used to when I was younger from small exercise. So it gets tired easily.
Okay, thank you very much, Ma. Well, I think that that is a symptom suggesting that something is going on. There are many things that can cause it. So I don't know if this is a man or a woman. So if the blood level
A man,
is low,
actually.
a man, okay, if the blood level is low from any cause, maybe like, okay, so let's go to Dr. Wesheni's specialty. So when people really have peptic ulcer now, they have peptic ulcer disease, or maybe they've been taking pain reliever or something, or H. pylori, something, or even the liver cirrhosis can cause an ulcer, or what can cause what we call portal hypertension. So an ulcer or portal hypertension can cause bleeding, and the bleeding may be like in form of black stool. So that can be making your blood level to be low, or any other cause of anemia, which is what we call low blood level, can make you tired. Now, so let's come to the heart. So cardiomyopathies, meaning cardio is heart, myo is muscle, and pathy means pathology of the muscle of the heart. So a cardiomyopathy, there are many forms of cardiomyopathy, and usually some of them, in short, about 25% or more of the causes, because you don't smoke, you don't drink alcohol. I want to assume that you've checked your blood pressure is normal, you've checked your blood sugar is normal, you've checked your cholesterol is normal, you've done HIV test, hepatitis B, hepatitis C, because those are all the things that can cause cardiomyopathy. So once you've excluded all the acquired causes of pathology of the muscle of the heart, then it can be genetic, meaning that the person was born with a genetic predisposition to having a pathology of the muscle of the heart, and there are different ones. So you would need to see a doctor, a chest x-ray, followed by an ultrasound of the heart, which is called an echocardiogram. Usually, so a chest x-ray will just say the heart is enlarged. It doesn't really say much, but it's usually like a first screening test. Is cheaper, even though there's radiation. So in LASUT, for example, scan of the heart is not expensive. At least it costs like half of the prices outside. So if you come to LASUT, you can easily get an ultrasound of the heart done, which, if there's a cardiomyopathy, will be able to tell you the kind of cardiomyopathy and will be able to start you on drugs for the cardiomyopathy, if it is the ones that will require drugs or surgery or anything. But like you have said, it is a symptom, something is going on, so we should look at what is going on. Thank you.
Wow. Thank you so much, Dr. Okununga. Your next question is, what can one do to prevent high blood pressure in pregnancy? And before you answer that, I know you said that for those that after pregnancy, they have high blood pressure. For me, for example, before pregnancy, I didn't have, well, I used to check and I didn't have high blood pressure. But after I gave birth to my second child, after my first child, I didn't have high blood pressure. But after I gave birth to my second child, I realized that my blood pressure started going up and down. I mean, now it's better, well regulated, of course, with medication. But you mentioned that if you have high blood pressure after pregnancy, it's because you've had it. or maybe I didn't understand fully. And because this person asked this question, I just wanted to tie the two questions together to get clarity, especially for people who are still, trying to get pregnant or in pregnancy right now.
Okay, thank you very much for the question. So I would talk about essential hypertension or chronic hypertension, and also talk about pregnancy induced hypertension. So chronic hypertension, which is the one that can occur whether you are pregnant, whether when you are not pregnant, is very common, like I said, in Nigeria. And the commonest chronic hypertension is essential hypertension, and the commonest cause of essential hypertension is no cause. Okay, so it can be in the family, it can be hereditary, there can be other things like you are fat, but or you are on the big side, but there are very slim people that have hypertension. So the first and foremost thing is that chronic hypertension essential, so there are like maybe less than 10 to 15% of hypertension that have causes like kidney disease, hormonal changes, like Dr. Obodo mentioned, hypothyroidism, hyperthyroidism, but those are 10 to 15% of the causes of the chronic. When we say chronic, it means that that is a disease that has come to stay, a disease that is there for 3 months. So once you hear any disease and they are saying chronic, apart from respiratory diseases that usually they will use 2 weeks for, pneumonia is already chronic, but most chronic diseases usually 3 months. Once the hypertension is there for 3 months, it is chronic hypertension. And 80 to 85% of the time, there is no cause. We don't know when it will start. So in Mrs. Kiki's case, if you had said that you had the hypertension when you were pregnant at 20 weeks of pregnancy, from 20 weeks up to the end of pregnancy, then that is pregnancy induced, meaning it is the pregnancy that induced the hypertension. That is different from chronic hypertension. So usually for pregnancy induced hypertension, that's why when you start antenatal, if in the first trimester, up to the second trimester before 20 weeks, and hypertension is peaked, that means that the person has been hypertensive. So that is chronic hypertension. But once from 20 weeks up to 37 weeks or 40 weeks of pregnancy, according to the O and G when they deliver, from 20 weeks down in the pregnancy, that is the pregnancy-induced hypertension. Blood pressure was normal all through, but from 20 weeks, the person became pregnant, then it is the pregnancy that induced it. And usually it can be mild, moderate, or severe. Sometimes after 6 weeks of pregnancy, that puperium, that's after delivery, if you still have hypertension around that time, and that is why that's very, very important. Before, sorry, I'll still respond to you, Miss Rachel, about the prevention, because I don't really think there's prevention to the pregnancy induced hypertension, because it is the pregnancy. It's just like peripartum cardiomyopathy, it is the pregnancy that caused the muscle pathology. Okay, so it's not like you can prevent it, but you can prevent, especially when you know that there's a family history of hypertension in your family, or you already know that you are living in Nigeria, and you know that 1 out of 3 people, they have hypertension. Prevalence is 30 something percent of hypertension in Nigeria. So what are the things that you can do to prevent it? And that you can do even before you get pregnant. I'm not saying that will stop pregnancy induced hypertension, but that would stop chronic hypertension. So those are the lifestyle modification, which include exercising, walking, walk for 30 minutes every day, walking fast like a soldier for 30 minutes every day. It is equivalent to jogging, equivalent to swimming, equivalent to treadmill. So you don't really need to go to the gym. Some people want to buy the treadmill and the bicycle ergometer in their house before they can exercise. No, all those ones are good, but just walking for 30 minutes, fast walking every day, 5 times a week, is very, very important in preventing. Reducing salt in your food. So we need sodium, because sodium is what is in salt. We need sodium, our body needs sodium, but we don't need excess sodium. So as a woman, just reduce whatever it is you have been taking, because what the books will say is that 2.3 grams of sodium. So if you look at the Maggi that you are using, you can, or any food that you buy, but so 2.3 grams of sodium is like 6 grams of salt. So all that English is a level teaspoon of salt. So when you want to cook for yourself, but remember that most of the time we are cooking for the family, but this will guide you in when you are cooking for the family. So what the books say about reducing hypertension as per reducing salt is you want to cook for yourself for the whole day. The salt that you should use should be a level. So you level the teaspoon, not a heap. You level the teaspoon of salt and pour it into a container. So the rice and everything that you use salt for should not be for yourself for that day, should not be more than that. And that is like 2 cubes of no. Okay, that level teaspoon of salt is like 2 cubes of no. So when you are cooking for days, you can just kind of like add that to it. Now, another thing is don't eat foods that are high in salt content, and don't add salt on table. So don't say that this food is too is the salt is not good, oh, bring salt for me, and then you sprinkle salt on it. No. Okay, so that is as per salt. Eat lots of vegetables. Okay, so for instance, you want to eat rice, divide the plate of rice into 4. 1/4 of that plate is the rice, then the remaining 3/4 is vegetable. So for you to get so you are reducing your carbohydrates, putting a lot of vegetable, and then the protein will be chicken, fish, or turkey. As much as possible for adults like us, we don't really need meat again, except once in a while. So we are talking about lifestyle, what you cook daily, most of the time in the house. It doesn't mean that once in a while you cannot eat meat, but most of the time, the staple protein in the house should be chicken, turkey, fish. But for the children, growing children, they need meat. So for instance, in Nigeria, the mom and the dad, they take big meat and then they give the children small meat. It shouldn't be like that. It's the reverse. It's the children that really need the big meat. Of course, it will be soft, and then we don't need it, or we just take a little of it. So fruits in between meals, eat on fruits. Cut the size of 1 or 2 apples. You want to eat pineapple, don't finish a whole pineapple. So the only thing that can be excess in all the food is vegetable. Fruit is very healthy, but at a time, 1 or 2 slices of apple size, of the pineapple, of the watermelon, right? Okay, what else? Low cholesterol. When you're buying oil, buy low cholesterol vegetable oil. The way to know it, apart from the fact that they will write it, you also look at what is listed. Saturated fat is the high fat. Unsaturated fat is a good fat. So if you see a oil, granite oil, and the unsaturated fat is more than the saturated fat, then that oil is good, right? Okay, so what else? Don't eat after 7 p.m. Sleep well, at least 7 to 9 hours a day. So those are the things that can prevent chronic hypertension. But when you get pregnant, it can induce many things. But you are in the hospital, I think the prevention of high blood pressure in pregnancy will be antenatal. Start antenatal early. Let them document your blood pressure is normal at presentation and in the first trimester. And so when it becomes elevated with time, they will check your protein and all that and give you drugs if you need it. So I think that's how I'll be able to answer that. Thank you very much.
Wow. It's like this webinar is for me because me, I have plenty of questions. But let it not look like Kiki, why are you taking up all our questions? Because we have a whole lot of questions. In fact, I have no idea how to take all these questions, but I'll give Dr. Okewale his questions and we'll circle back again. All right. So, Dr. Okewale, why do IVF fail? What can you do differently to make it succeed? Thank you.
So, thank you so much, everybody. So, it's a common question. Why did my IVF fail? People ask that question every time. And the way I like to answer that is to relate the whole process or liken it to the work of a farmer, because the work of IVF is very similar to the work of a farmer. Now, if you have a farmland and you want to go into farming, you will need a good seed. You will need a good farmland, which is the soil. You will need a good farmer. And finally, you will need a good environment in which your farmland is. Now, the equivalent of that in IVF are this. The embryo or the egg that forms the embryo is equivalent to the seed of the farmer. The inside of the womb itself is equivalent to the soil or the farmland. The environment in which your farmland is in, the equivalent of that in IVF is the totality of the body of a woman. Because don't forget, the embryo and the womb itself are inside the body. So the totality of the body is the environment. And then finally, you need a good farmer, which basically is the IVF clinic and their expertise and their success rate. So why do my IVF fail? We'll take it one by one. We look at the embryo. Before you can say your embryo is very good, we are going to the seed now. There are 5 things that must be okay. And it starts with the number of the egg that was produced. The more the egg, the better. So that's number 1. The second thing you want to do when you are reviewing is how many of the eggs that were produced are viable. How many of them were mature? How many of them were immature? How many of them were overmature? And how many of them got fertilized? For example, if you got 20 eggs in an IVF cycle and 18 of them got fertilized, that's a very good news. So that's the second thing. The third thing is, when was the embryo transfer done? Was it a day 2 transfer? Was it a day 3 transfer? Or was it a day 5 transfer that we call a blastocyst? The best day to transfer an embryo is day 5. Why? Because basically what it means is the embryo in the laboratory has survived up to day 5. And usually those embryos, by the time you transfer them into the womb, they just continue their growth. Not every embryo that started on day 1 reached day 5. So that's number 4. The next thing you want to know is, what was the grading of the embryo that was transferred? Because we do grade embryos. We grade them grade A, B, C, D, E. The best grading of embryos are the grade A's and the B. So that's important. And then finally, as per embryo alone, we want to know how many embryos were transferred. Generally, we know that if you transfer 2 embryos, the chances of getting pregnant is higher than if you transferred 1 embryo. But there is no added advantage by the time you are going above 3 embryos. So when you look at the history of a woman who says, why did my IVF fail? And you look through the embryo and all these 5 things work, then you can easily tick the box and say, I don't think it was your embryo. Then you go on to the next thing, which is the lining of the inside of the womb, which is equivalent to the soil or of the farmland. What are the things that could be inside the womb that could prevent implantation? We call it implantation failure things. Do you have fibroid inside the womb? Do you have a polyp? Are there adhesions there? Are there scar tissues there? Those are the things that should have been checked before you go on for the IVF. And some of the investigations we do check those things. So that is as far as the lining of the womb is. If there, for example, there are multiple fibroids there, and you've been advised not to take out the fibroid before the embryo was planted there, then we can say maybe it was the lining of the womb. So that's the number 2 thing. The third thing you want to check, like I said, is the environment, the totality of the woman. Were there some things that were missed out? For example, if a woman had an active thyroid, it can affect the embryo and the womb and the lining of the embryo or the implantation of the embryo. If the woman has an uncontrolled diabetes that's not well controlled, that's an external thing. That's a bodily environmental problem. If there is hypertension that is not well treated, if there is excessive weight, obesity, it can affect failure of embryo transfer or transplant. So a woman needs to be checked in totality. And sometimes there are things called killer antibodies that some women carry. And they carry it in such a way that any embryo that goes inside the womb, they attack them. So that has to be checked for as well. You find some women, I'm not even talking about IVF now, who have what we call recurrent miscarriage. Every time they are pregnant, 6 weeks, 8 weeks, they have a miscarriage. In such women, we check to be sure they don't have antiphospholipid antibodies. These antibodies attack the embryo of fetuses. So those are part of the things that needs to be checked. And then finally, like I said, the farmer. If you did your IVF first time, second time, third time in a fertility clinic, maybe you need to change the farmer. You need to do your due diligence on the farmer, which is the IVF lab. You know, what are the quality of their staffing? What are the quality of their equipment? What are the quality of their success rate? Those are the things that you need to. Unfortunately, you can check all these 4 things that I've mentioned. That is the seed, which is the embryo, the soil, which is the lining of the inside of the womb, the environment, which is the totality of the woman, and the clinic. And you might not find anything wrong. In such situation, we say maybe one is unlucky. Just like a farmer would say, maybe I had a bad harvest that year. So it does happen. IVF is not 100% guaranteed. We give statistics. And each clinic has their success rate. So, but before you can reach that conclusion that it's an act of God, or maybe you are unlucky, you would have gone through all those 4 things. And if nothing was found wrong there, then usually the advice is, what are we going to do different in your next cycle? So those are the things that cause IVF failure, and how you can know what to do different in your next cycle.
All right. Wow. Thank you so much. We always enjoy to hear about the farmer. It makes everything very easy to understand. Thank you so much for that explanation. Your next question is this. So these questions, we're picking questions from Instagram, from social media, and we're also picking from the StreamYard and the YouTube. So we're making sure that we're spreading the question round. So this question says, when coming for IVF, if a couple cannot come together, who should come first?
Okay, so usually we advise they come together, truthfully. Infertility is the only disease in the world that affects 2 people at a time. For example, if you have high blood pressure, it's only your own problem. If you have cardiac problem, it's an individual thing. But infertility is a couple disease, it's a couple problem. So the advice usually is come as a couple. But if one person has to come first, then it has to be the man. And the reason for that is, out of the 5 or 6 investigations that are needed to clarify issues, the man's own is only 1, which is their semen analysis. And it is not an invasive procedure. So if somebody is to come first, we will advise that the man comes first and does his own semen analysis. Then the woman can continue with the other investigation. The tragedy is, a lot of time in the clinic, it is the woman that comes. So the woman does all the 6 tests, all her 5 tests, and the man does not come for his own in time. And the years pile on, and the woman is running from some place to the other place looking for a solution, and the man still does not come. The age is catching up with the woman, and at the end of the day, the simple problem was the man, which could easily have been dealt with at an earlier stage. So if somebody had to come first, the man, but preferably to come as a couple, because it is a couple problem.
All right. Thank you very much. Thank you so much, Dr. Wosheni, Dr. Kingsley Obodo, Dr. Okunuga, and Dr. Babatunde. We have a lot of questions. I'll try to take maybe 1 round and see if we can take another round, because we have about 18 minutes to go. And we still have over 50 questions. And this is why, being honestly, people would definitely want to consult with you after today, whether we are able to take their questions or not, because the questions we're taking right now is not personal. You know, you can ask them more questions to dig deep to even know more to help. So that is that. All right. So for Dr. Okunuga, I'm sure hormonal imbalance was for you. So I am interested in knowing about hormonal imbalance. And that question is not quite expressive. It just says, I want to know about hormonal imbalance. I don't know if there's an information that can be short that you can share with us about hormonal imbalance. But before you answer that, I think for me, hormonal imbalance, I would want to tie it to um, what's this? Menopause, premenopausal hormonal imbalance. And because uh, I'm not reaching menopause anytime soon, but I've I've actually heard different stories and I've seen different people have a lot of different signs when they're reaching menopause. And you know, a lot of them say it's the hormonal imbalance and the things that are happening. I had a friend, big auntie of mine, that suddenly felt like there was hair on her face every time she's doing like this in public, and you know, and they said to her it's hormonal imbalance. But most of the things we hear with hormonal imbalance is probably, you know, hair growth, hair, and stuff like that. I don't know if you can, you know, just slightly share with us the causes of hormonal imbalance and how we can prepare for it. I don't know if that's a question, but how can we prepare ourselves for hormonal imbalance? Because I guess hormonal imbalance will have to happen. Dr.
Okay,
Okunuga.
so I think that the gynecologist,
Yeah.
I would just say a bit about the heart, but it's actually the question to the gynecologist. So what I would say before I start talking about estrogen and progesterone, will be to talk about hormones that we think of. Like here, there's the thyroid gland. So at least you should check your hormone there to know your thyroid hormones are normal. Okay, because if they are low, it's a problem. If they are high, it's a problem. But that's just to mention that that is not what this question is about. So just like Mrs. Kiki had alluded to, after menopause, so what makes us women generally is that we have more estrogen than progesterone before menopause. Okay, so but as we reach menopause, then we have less estrogen. And so one of I try to shy away from talking about the cardiac diseases that are specific to women and men, but this question will kind of like bring it to fore now, because the estrogen kind of like protects us from some major cardiac diseases like heart attack. So for instance, when a woman, at least in Nigeria, okay, when a woman comes to the clinic at maybe 30 years and they're complaining of chest pain, it's not going to, or maybe a 20-year-old female complaining of chest pain, and you know they think it's cardiac, it's probably most likely, if it's not musculoskeletal, it will probably be Dr. Owosheni's specialty, because peptic ulcer can give reflux, can give chest pain, reflux, that is acid going to the from the stomach going to the esophagus, can give chest pain, and all those other things that she had talked about. But for heart attacks, it is very unlikely that a woman below 40 years of age majorly will be having an heart attack, except if maybe they were born with type 1 diabetes and it was not controlled, or they have very high cholesterol. That's not the cholesterol that comes from food intake and all that, the ones that they were born with. So total cholesterol in the range of 400. Okay, normal should be less than 200. Then those kind of things can block the arteries, or we call them in layman's language, pipes supplying the heart. But by and large, those are the few exceptions. A woman is generally protected from heart attacks because of the estrogen level that they have. So as they now reach menopause, then the risk, so the man is not protected because they have testosterone. So as they now reach menopause, then the risk that the man has, they now start having that same risk, because they now don't have enough estrogen again. They now have more progesterone. So it depends on age, majorly. Some people reach menopause faster than others, but the major thing that I would say as a cardiologist would be that the estrogen, which is what makes us a female, will protect you from heart attacks, myocardial infarction, angina, and all those diseases related to blockages of the artery. I'm not talking about hypertension. You can have hypertension from any age. You can see an 18-year-old person with severe hypertension, but majorly the disease, like them having complaints of heart attack, the estrogen will protect a woman from that. But when they reach menopause, then they would have the same complaints as a man. They are no longer that protective again. So I think the O&G doctors will be able to explain better, about the hormonal imbalance. But that is a bit that I can say about it. Thank you, ma'am.
All right, thank you very much.
Okay, thank you so much, Doc. I guess the question was somebody who wanted to know more about hormonal imbalance. I'll quickly just explain the hormones in a woman and how they are interrelated. Now, at the base of the brain of a woman, there's one small organ called the pituitary gland. It produces 3 hormones called FSH, that is follicle stimulating hormone, LH, which is the luteinizing hormone, and prolactin. Now, what happens every month is those 3 hormones, they keep working on the ovary. And their main function is to make sure the ovary ovulates in that month. That is, an egg is released in the month. Now, once ovulation occurs in the mid-cycle, the ovary will produce another 3 hormones. One of them is called estrogen, which is the female hormone. The second one is called progesterone, and a tiny weeny bit of testosterone, which is the male hormone. Now, what those 2 major hormones that the ovary produce, that is estrogen and progesterone, their main function again is the egg that has been ovulated. They will be waiting to see whether pregnancy will occur. If pregnancy occurs, they are the ones that will maintain the pregnancy up till 12 weeks when placenta takes over. When those hormones wait for like 14 days or 15 days and no pregnancy occurs, the estrogen and the progesterone will act on the lining of the inside of the womb and make a woman to menstruate. And the cycle continues. So it goes around like that every month. The FSH, the LH, the estrogen, the progesterone, the testosterone, pregnancy or no pregnancy, menstruation. Now, if there's any imbalance in that cycle, they now cause problem. That's what we mean by hormonal imbalance in a woman. So, for example, let us say the prolactin, which is coming from the pituitary at top, is excessive. It will disrupt that balance. And what it will do is menstruation will not occur, and ovulation will not occur, and pregnancy will not occur. The same thing happens when a woman reaches menopause. The FSH and the LH and the prolactin from above, they still keep acting on the ovary, but the ovary does not respond again because there's no egg to produce. So there will be no estrogen, there will be little or no progesterone, and there will be no menstruation. And then we say a woman has reached menopause. So all forms of imbalances occur if anything happens to that cycle that I just explained. Some of the disease processes that can disrupt that hormonal balance are things like polycystic ovarian syndrome. In polycystic ovarian syndrome, that tiny testosterone that the ovary is supposed to produce, it is excessive. Instead of producing just tiny, it produces excessive. And what that does is it will not allow ovulation to occur, and it will start giving some distressing symptoms. The kind of symptoms that a man who has testosterone will have: hairy parts, hairy chin, hairy hoarse voice, pimples, and all sorts of things that people who have polycystic ovary have. So basically, that is what hormonal imbalance is all about, and that is what the hormonal cycle that happens every month is all about. I hope that answers it. Yeah.
Yeah, actually, it does. Very deep. Thank you so much, Dr. Okunuga. Thank you so much, Dr. Kewale. This question is for Dr. Owosheni. I believe, what could be the cause of heart palpitation and what can one do to ease the symptom? I think that's you for Dr. Okunuga.
I'm
Yes.
actually happy this time to say that that's not my question.
Yes. We
And
leave for
I'm
Dr.
happy
Okunuga.
to take it because when I saw the hormonal imbalance, my heart skipped. Okay. Okay, so
Okay.
palpitation means that you are aware that your heart is beating, so which is not normal. So the heart beats all the time. So the heart beats at least 60 to 100 times per minute. So that is the pulse rate. So when you do your blood pressure, you see another value below. That is the pulse rate. So it will tell you your value, whether 80 beats, but anything between 60 to 100 is normal. Some people have 50 to 60 as also normal, but less than 50, we are worried about it. So you can just imagine the heart is the only organ that keeps working and working and working till we're 100 years of age and more, you know. So, but we don't hear it. So when you are aware that your heart is beating, or another person can even feel it, or they can even see it, or you can know that it's beating, then that is palpitation. Now, there are some normal causes of palpitation, like if you have an exam, you are preparing for an exam, or you have a deadline, or you need to pay money, you know, all those things. You are coming on stage, we are presenting now, and all those kind of things. Something you can have palpitation. I mean, that can be like anxiety. If you take coffee, the caffeinated one, it can give you palpitations. So those are like normal, they should quickly go. So, but if it is not those ones, then you are not anxious, you know, then you have palpitation. There are many causes of it. And starting from the electrical activity to the heart. So the way the heart is beating 60 to 100, it should beat bing, bing, bing. You know, that kind of thing. There's a regular beat to it. So when you even put your hand to the pulse, you should be able to know when the next one is coming. But some people don't just beat, 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 and all that. So the commonest electrical abnormality of the heart, that is the common, so we call it arrhythmia. I'm trying not to use the terminology, but the commonest abnormality electrically of the heart is atrial fibrillation. It's very, very common. You need so it may not show on your monitor because it is just the rate that will show, but that is beating irregularly, it may not show. So you need a doctor to put their fingers to your pulse and to let you know whether it's beating regularly, and you need to see a doctor for that. Of course, you would have palpitation, and if it is not treated, you are not on strong blood thinners, it can cause strokes. Okay, so the electrical activity of the heart, when they are abnormal, they are beating abnormally, they can cause palpitation. All the heart diseases too, heart failure, cardiomyopathies, all of them can cause palpitation. So when you are having palpitation and you know that there's no cause, like it's not like you borrowed money from somebody, you don't know how to pay the money, or you took coffee, or you know, even if even the physiological ones should not be consistent. So you know that it is not all this stress, you're not preparing for an exam, then you should see a doctor. So the first thing to do is to do an ECG. Also, we mentioned the thyroid here. If it is beating excessively, if you do a thyroid hormone, and so maybe the final thing I would just say is that we said you should check your blood pressure regularly, check your blood sugar at least once a year, check your cholesterol at least once a year to know the values, and check your thyroid hormones. Just say you want to do a thyroid function test. So if it is low or high, especially when it is high, it can cause palpitation, and all these things can be treated. So we have drugs that will give, that will slow the heart rate. And if you do your blood pressure monitor is showing your pulse above 100, like we said, it should be 60 to 100. I've seen 120, 140, 200. You should present at the hospital immediately. Okay. So I think I'll just stop there.
All right, thank you. All right, so I'm just going to take two more questions and we're going to call it a day. We have so many, I don't even know. I'm just doing abracadabra now. So I think I'll take this on tubal blockage. Aside IVF, what other solution is there for tubal blockage? Who is taking it?
Dr. Bode, will you do that?
Okay. Thank you very much for that question. What we know in terms of conception is that fertilization takes place in the fallopian tube. Now, there are different causes of tubal blockage. Some of these causes are extrinsic, some are intrinsic. By extrinsic, I mean that they are external things from outside that are blocking the tubes. And this could mean adhesions from people who have endometriosis, people who have had previous surgeries in the past, forming adhesive bands that may obstruct the tubes and prevent the two gametes from meeting. That is one. Then occasionally you may have intrinsic tubal damages. This can not only affect both the functionality but also the mechanical functions of the fallopian tube. By functionality, we talk about the fact that we know that the tubes contains tiny structures which we call cilia. These cilia, they help in beating the oocytes, which is the egg, towards the ambulary region where fertilization takes place, and also aid in the spermatozoa reaching where the oocytes are located for fertilization to take place. Now, for people who have intrinsic damages as a result of previous infections like sexually transmitted infections, the commonest one we talk about is the chlamydia infections, that causes damages not only the physiological functionality but also the mechanical functionality. In the past, people used to talk about, before the onset of IVF, you talk about tubal surgeries, tubal repairs, tubal anastomosis and repair. But we know that apart from the mechanical functionality of this fallopian tube, the physiological effect is also affected. And this can also be an impediment to even the conception itself. Either you end up having impaired functionality that may end up, even if fertilization takes place, you may end up having a trapped embryo resulting into ectopic pregnancy. So people don't want that. So with the advent of IVF, in fact, tubal operations are obsolete. Nobody does tubal surgeries again. In fact, I can't remember the last time I've heard of any tubal surgeries being performed or otherwise. Now, some people talk about that process that if you do a HSG and the HSG comes out that you have bilateral tubal blockage, there are two things that could be the effect of this. Number one is that there could be either there are genuine blockage or that the tubal undergoes what they call tubal spasm or contractions of the fallopian tube that may be picked up in the HSG as tubal blockage. That may not necessarily be. So that's why you hear people saying that, they told me that I have blocked tubes, but I eventually conceived. That may not be really genuine blocked tube, but probably you had tubal spasm, and that's why you were able to achieve natural conception. In order to separate either a tubal spasm from a genuine tubal blockage, you now need to do a further evaluation, which is what laparoscopy and dye test, where the woman will now be completely put to sleep and the dye will be injected and you'll be able to visualize the dye in the intrauterine cavity. That being said, in the past, people used to talk about tubal flushing, but that in itself doesn't work. It doesn't work. The same process that is used for tubal flushing is the same process you undergo when you are doing your HSG. So whatever your HSG could not do, whatever intrinsic blockage that the HSG could not flush, your hydrotubation or tubal flushing will not work. So sadly, where there are tubal blockage, IVF still remains the only viable options for such women.
All right. Thank you very much, Dr. Obodo. I'll take the last question. If I didn't take your question, please do not come for me. This is not personal. We are just really out of time. I still have so many questions, but I will take this as the last question. 11, testing negative at day 11 post embryo transfer. Does it mean IVF has failed? No period or any form of bleeding?
Okay, so normally after the embryo transfer, what we expect is just like normal conception. When you conceive, you normally conceive around your day 14 of your menstrual cycle for somebody who is a 28-day cycle. And you only know you are pregnant until you miss your period 14 days later. Now, the same principle works in IVF. After the embryo transfer, we expect to know whether you are pregnant or not when we do a pregnancy test on day 14. Now, embryos behave differently. Some embryos get to the finishing line in time in such a way that by day 9 or day 10, some women cannot wait and they do the home pregnancy test and they already see signs of implantation. The pregnancy test comes back positive. And there are certain women as well where the embryo is slow, that by day 14, when they will ask them to come for the pregnancy test, it comes back negative. The next question we ask is, are you bleeding? If they say no, we say give it a few more days, because some embryos might take their time, maybe up to day 18, before the HCG, which is what we are checking inside the blood, starts showing in the blood. So on the average, it's 14 days. But the common theme in it all is, are you bleeding or not? So if you had a test done at day 11 and it comes back negative, and you are not bleeding, it's very likely it is negative. But because you are not bleeding, you never say never in medicine. You still have to wait for that up to that day 14 to have a more confirmatory test. I'm sure the test you did on day 11 is the home kit, which sometimes has the false positive, false negative aspects to them. The day 14 test is supposed to be a blood test that will quantitatively check the HCG. So as long as there's no bleeding, I think you should keep your fingers crossed and wait till day 14 when the test, you will properly have an answer to that question.
All right, thank you very much, Dr. Okewale. So they are saying, please give them more time. Doctors are busy. Doctors are very busy people. And there's work tomorrow. We don't even know if they're at work right now. So please, don't worry. We promise to do this again and again and again. Now, if you're not following St. Ives on social media, make sure you're following. We have live session every Thursday. Every Thursday, we have live session and free health consultation on our Instagram page. So you get to ask your question. That time, we have more time. Well, it's 1 hour, but then it's just one doctor focusing on your topic. And we promise to bring more doctors and bring Dr. Woshene and Dr. Okunuga as well as their time permits. But for today, we would not be able to take more questions because the questions never end, honestly. It keeps coming in, and I already promised that they will be out of here by 6 o'clock so they can also take care of themselves. However, this particular one, Dr. Babatunde or Dr. Obodo, can someone outside Nigeria start steams in their location before coming to Nigeria for egg retrieval and transfer due to not getting enough time from work? So I'll take that one. Yes. Who's taking it? We don't have time. Who's taking it?
Okay. Yeah. For every IVF treatment, in fact, we have quite a lot of our clients are in the diaspora now. Yes, the treatment can start from over there, depending on which type of treatment you are going through, whether it's a recipient cycle or whether it's a donor cycle. But what I will advise is you contact our hotline number, 0703 424 6413. Everything will be laid out for you there, and you talk to one of our fertility coordinators, and they will help you in all the logistics and in such a way that you don't waste too much time by the time you come to Nigeria for your treatment.
All right, thank you very much. So we've received a lot of people saying they want to have one-on-one consultation or ask questions with Dr. Owosheni, with Dr. Okunuga, and of course with Dr. Obodo and Dr. Kingsley. Dr. Owosheni and Dr. Okunuga did share their phone number earlier. I want to ask for their permission because we're going to be sending an email to everyone who registered for this webinar. Is it okay to share your contact with them as well? Dr. Okunuga and Dr. Owosheni. Is that okay?
Well, no problem.
I'm not sure. The reason I'm asking is because for St. Ives, we share the link where they can book a consultation, not really personal phone numbers. But because you're not on the TeleDoc app, I know that outside Nigeria, doctors you can have number of the organization of the hospital, but they don't share one-on-one contact. And that's why I'm asking. I don't know what your rules are. Yeah, you want to say something, Dr. Okiwade?
We've shared our number, I think, for those who were on the call. For many reasons, it's difficult to attend to everybody that wants to reach you. So it's because you are putting us on the spot. I'm sure that it's hard for us to say no, but I don't know.
Yes, I agree with you. I think what I would do is
I'd rather just not have it. Yeah.
Absolutely.
I think that they can go through St. Ives, if they want to see any of the specialists, they can always contact the hot number and ask that they want to see this particular specialist. That would be okay, because we really don't know the people that came for the presentation. So anybody just calling, again, for me, I would even prefer that they send WhatsApp messages so I can read it and chat with them. But to really attend properly to patients is good for them to come to the hospital. So if the hospital is doing a virtual thing, we can join in the virtual thing. But I just want to say, as a final note, I forgot to mention that ECG is very important for that person talking about palpitation. And then to seek a cardiologist review. Thank you.
All right. Thank you so much. And that's why I had to ask. Dr. Okiwale, you were going to say something.
No, I just wanted to buttress what they've already said. I think anybody that wants to contact our doctors should go through the hotline, and then we will, as soon as possible, try and get them on the TeleDoc app, because people who are on TeleDoc app have been properly screened. So they can have a one-on-one there in a proper fashion rather than just sharing.
Absolutely, I do agree. Dr. Owosheni and Dr. Okunuga, for your information, TeleDoc app is a telemedicine app that was created to bridge the gap of time and make sure that doctors are also getting value for their time. So I'm sure that, just like you've mentioned now, over the years, people call you every now and then, regardless of the time, with no respect to your time, and they start, in fact, we've had situations where people will call and say, hold on for this person. And, people abuse the access and the contacts that they have. And so what TeleDoc app does is you're registered properly as a doctor and you open your slot, your own time, your free time. You open the time that you want to consult with people on the telemedicine app. And for people to book you, they have to pay ahead. So that once they're booking you, you accept the consultation or not. It is up to you. Once you open your time slot on the app, we have some doctors, they open their time slot 6 p.m. to 8 p.m. Some open their time slot in the morning. Anytime that works for you, your own free time. And you can also use that to also have an extra stream of income. That's what we created it for doctors to be able to have extra stream of income, for patients to be able to bridge the gap. You're in the US, you're in the UK, you're in Nigeria, but you don't have the time. You can actually consult. It's a video consultation and it's one-on-one. And there's a lot of screening that goes into it. And so we will reach out to you. It's not a St. Ives product. I am the CEO of TeleDoc app. And so we have over 2,000 doctors, over 600 doctors on the app now, and over 2,000 patients on the app. And consultation goes on every day. In fact, every 30 minutes, there's somebody. And we have doctors from different specialty, cardiologists. I'm not sure we have Dr. Woshini's field yet, so I'm excited to quickly onboard both of you on the app. But we've had a lot of patients in Nigeria and outside Nigeria that are consulting on the app. And the earlier we bring you on board on the app, we can share your link with everyone, because you have a personalized link when you are on the TeleDoc app, and people can always consult with, and you can accept the consultation or not, really. Once you accept and you have the consultation, your wallet shows the money that is yours. So we will reach out to you to share all of this information with you, so that we can onboard you real quick, so that you can have your consultation. We no longer want people to tap our doctor's brain. At least let them also get value for their time. So we would reach out to you. But if you're trying to reach Dr. Obodo, here is this TeleDoc app link on the screen. I don't know if it's clickable, but please do try to click it. However, we would also send an email with the links to Dr. Okewale and Dr. Obodo's TeleDoc app, so you can consult with them virtually. I see a lot of, we want to have one-on-one. And yes, with this, you're going to be able to. And as soon as we onboard our two doctors as well, we would be able to. These questions from Italy is eating my head, but gosh, I don't have time. So I'd like to say thank you, thank you, thank you. You can also send a message. You can also send a message to our social media handle. We will try to answer your questions if we can. If not, we will also give you the link of how you can reach out to all the doctors. I'd like to say a very big thank you to Dr. Wosheni. Thank you so much for being here today and for opening up the webinar with your wealth of knowledge. Dr. Kingsley Obodo, thank you so very much for being here. Dr. Okunuga, thank you, thank you, thank you so much for being here. Dr. Okewale, thank you so much for being here and sharing. I'm grateful to each and every one of you. I would also like to say a very big thank you to St. Ives Specialist Hospital for bringing the first of its kind of webinar, a free health consultation for women this time around. But I'm sure the next webinar we'll do would, accommodate both men and women. Yes, we have a lot of thank yous coming in. Thank you so much for hosting this webinar. Thank you so much, St. Ives team. Thank you to all the behind the scenes staff that has made this possible. It takes a village, I can assure you. Thank you so much to the business development team, the HR team, and the sales and marketing team of St. Ives for making this possible. Thank you, Rosemary Benvasi, for your support and making this possible as well. To all our audience, we're very, very grateful for your time as well. If you have more questions, please send a DM. Make sure you're following us on our social media page, which is St. Ives Specialist. If you're not following us yet, do not miss out on the live sessions that we do every Thursday. Till we meet again, make sure you stay healthy. Like our doctor said, please, 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 do not just self-medicate. Go to the hospital. Go to the hospital. Make sure you go to the hospital. And I know a lot of times we just feel, oh, it's just malaria. A lot of people have been affected deeply by self-treating themselves. However you're feeling, go to the hospital and seek expert knowledge and consultation. Thank you so much, everyone, for your time. That will be the end of this free health consultation. Ask the expert. I'm sure that the experts have been able to do justice to all the questions that we've asked here today, and I do hope I've done justice to the hosting. Thank you so much, everyone. That will be all for now. Till we meet again, like I said, stay healthy and visit the hospital where you need it, okay? I don't know. I was going to ask parting words from my doctors. I don't know if you have parting words, but I can give 1 minute each if you have parting words, and then we'll make it a wrap. Dr. Owosheni, do you have parting words for us, please?
Okay, well, I do want to say something that I didn't really put in the presentation, but I find that it's actually very important, and it's commonly found in women, and that is, well, to put it mildly, well, it's an old terminology. We have a newer one, but it's called fatty liver disease. Okay, it's becoming epidemic in our society now because we have a lot of obese people, sedentary lifestyle. They don't move around much. They're always in the car, so they get from their house into the car, from the car to office, then their seats all day, then from the seat to the car again. So we have a condition that is becoming, like an epidemic, and that is fatty liver disease. Again, like many chronic liver diseases, no symptoms, none at all. You may never know until you are doing a scan for something else, maybe for abdominal pain, for routine medical evaluation. So it is actually a serious condition, and if you do not do what you need to do, like losing weight, doing the kind of exercise Dr. Okunuga has, talked about, you may end up having liver cirrhosis or even liver cancer. So I think that was what I haven't really mentioned, and I just want to put out there. Thank you.
Thank you so much, Dr. Owosheni. Very, very important information. Thank you. Over to you, Dr. Obodo. You are muted.
No,
All right. Thank you.
yes. So once again, just to wish our female women happy International Women's Day. Let's take health as our priority because health, they say, is wealth. And one of the fundamental, like I mentioned earlier on, that the bedrock of every nation is the woman. So when you have healthy women, you have a healthy nation. So I want to encourage each and everyone to take full charge, seek information, seek help when needed, and also stay and live a healthy life. Thank you once again for having me on this platform.
Thank you so much, Dr. Obodo. Over to you, Dr. Okunoga.
Okay, thank you. So again, just to emphasize that as women, we are the major person in the house that can make things work. Like we have said and emphasized, hypertension. If there's one disease that is like 80% of the diseases that we see every day, it is hypertension, and it is no respecter of any age. So please check your blood pressure. Encourage your husband and children and everybody that you know to check their blood pressure and their sugar and their cholesterol and all the other hormones. And please, at least once a year, do this thing. And as a family, work together. I remember growing up, my grandfather, once you greet him, he would just take us to the living room and we'll jog around the center table. It was a normal thing. We enjoyed doing it as children with him, and evidently he was doing it as exercise. We are also doing it. We didn't know we're playing with grandpa. So please let it be like a family routine. 30 minutes, let us work together, let us jog together. It's very, 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 very important. Eat healthy. Don't give your children meat pie, ice cream, coke. Growing up, there was no coke in the fridge unless it was parties. So let it not be like all these things are accessible to the children, because just like Dr. Wosheni said, obesity, children, no, they just sit in front of the TV. You are driving them to school. There's no playing ground in school, and you are giving them meat pie, ice cream all the time. Let it be like something like they've done something good. Once in a while, you give them these things. Let them eat healthy, these fruits, vegetables that we are talking about. So that would be my lasting word, because hypertension can cause serious heart diseases, heart failure, heart attacks, and kidney problems, strokes, and all that. So please, let us check all these things. Let it be that we women, we have taken it as our responsibility to do these things for the family. Thank you.
Thank you so much, Dr. Okunoga. Thank you so much. Dr. Kewali, over to you.
Yeah, thank you, everybody, for this wonderful webinar. I just want to remind us all that every human being has a right to the enjoyment of the highest attainable standard of physical and mental health. Individuals and couples have the right to decide the number, the timing, and the spacing of their children. And infertility as a disease process can negate this realization of this very essential human right. Fertility is a human right issue, and every woman or every couple has the right to have their own children. Thank you.
All right. Thank you so much, doctors. Thank you for your time. We're very grateful. This will bring the webinar to a close. We're grateful, and we hope that when we invite you again, you would accept to share with us from your wealth of knowledge again. Thank you so much, everyone.
Thank you.
All right, thank you.
All right. I'd like to say a very big thank you to our audience. Thank you so much for joining us. Like I said earlier, if you are not following us on social media, do well to follow us on social media, St. Ives Specialist. Okay, we have our webinar, our live session every Thursday, 5 p.m. to 6 p.m. Thank you so much to all the team members and those backstage. It's been an amazing time. We hope to do this again. Bye for now.